If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome everyone to Health Further. Excited to do the roll-up show this week. I have a guest host. Marcus is still in Saudi Arabia solving all the world's problems, which is will be good to hear his update next week. But I have Paul Kappelman as a guest host this morning. Thanks, Paul. Appreciate you doing it.
Morning, Nick. Good to see you. Sorry it's remotely. It's been a while since we've seen each other live, but
No, I know you're out west right now in ski country.
yeah, I am got 15 inches out here in Utah. So it's President's Day weekend, so it's gonna be busy and crowded. But I'm looking forward to getting out first.
It'll be fun for the ski slopes on President's Day.
And I get both of my girls headed this way from Virginia.
Oh, nice.
Here short. So that's the best part of it.
Yes. That's the perfect Valentine's Day for you, probably. So.
Exactly.
Yeah. Great. Well, before we start, maybe give the audience just a little bit of your background. I mean, you're a health system operator that has moved into private equity is my summary, but maybe give like where you came from and what you're up to today.
Yeah, that's a good summary. I think really almost 30 years in healthcare operations. And I think that's key is that I'm an operator. I'm today doing a lot of operating advising, sitting on a few boards for my former private equity sponsor, which is Morgan Stanley Capital Partners. But at my core, really healthcare operations, hospital operations is where I spent the bulk of my career. I worked for HCA, Triad, CHS, and then we started up our own company called LHP in Dallas. That was acquired by Ardent. I was the chief operating officer of Ardent through the merger. And then I joined a private equity-backed fertility company as a CEO and led that to a successful exit. And since then, have been doing consulting, operating, advising for several PE firms, but primarily Morgan Stanley Capital Partners, really a great sponsor, and nothing in the provider space right now. Really about support. Most recently, joined the board of Prescott's, which is a clinical engineering company that sells to health systems, ASCs. So that's what I'm up to these days. I'm really enjoying it. One of these days, I may get the itch and go back to run something. But for now, enjoying some of the flexibility of being able to do some consulting.
Yeah, excellent. Well, let's dive into the stories. So in the Wall Street Journal, the CPI came out this week. The Journal covered it. Inflation sort of continued to tick a little bit higher. It's still not as bad as it was a couple of years ago, of course, but it definitely was up for this month. And that made the markets nervous. And I think the Fed is going to be pretty hamstrung and be able to cut rates in this environment as inflation is going up. So we just kind of keep track of it. And there's a good graph here. For people that are listening, I think everyone will recall, right in the exit of COVID, as people started moving around and buying stuff again, inflation really shot up. And then it's been over the 2% target since then. Not as bad. It was the core was at 3.3 this month and the overall 3.0. Any thoughts about inflation, Paul?
Yeah, it's just reading the story, kind of the details behind it. There wasn't really a bright spot. Normally it's like, yes, but, the core or the rents or things that you can pull out and tweeze it and sort of make it look good. This was sort of across the board a little bad. So not altogether surprising for me. I think about, regardless of where you sit on politics or what you believe about Trump's economic plan, it's going to take some time. I mean, if it works and if you believe it's going to work, still, it's not going to happen in a quarter or probably even 2 quarters. It's going to take greater part of a year before we start to see the impact of those policies.
Yeah, I think that's right. The Doge cost-cutting effort, of course, is getting tons of press coverage. And I think you're exactly right. If they're able to cut significant spending, it might have effects on, what the government's willing to support, which could be negative to healthcare. We'll cover that maybe during the whole show. But that will help the bond market feel more comfortable that U.S. debt is secure, and that could then bring down rates and eventually bring down inflation. But that's going to be a year or maybe longer to have the effect if it's successful. And of course, lots of fights in D.C. about it.
Yeah, and obviously tariffs and the impact they have is meant to bring growth back to the United States and jobs back to the United States and products being bought, but that conversion doesn't happen overnight. It takes time to transition. It's unfortunate that many companies didn't make some of those transitions earlier and still buying a lot from some of our partners and non-partners in China. But that's going to take time to if you believe it's going to happen, which reason to doubt it, it won't happen overnight.
Right, right. So I think we're going to be in this elevated inflation over 2%, I think, for the foreseeable future. Hopefully it will stay under 3 to 4. That's, to me, the best case scenario, kind of bumpy inflation and somewhere 3%, 2.5 to 3.5, somewhere in there. Okay, moving on. There were two stories, three big VC deals that I want to cover in our VC segment. So Prenuvo, I guess is how you say it. They're this full body scan that really celebrities started doing, and then a bunch of longevity and folks have been starting to. They raised $120 million to grow. Do you know this company? What are your thoughts about that?
I don't know the company, and I'm curious to compare notes with you on sort of the whole body imaging, because we both are into wellness and longevity and have read a lot of the same stuff. But I probably err on the side of I'm not sure I want to do this. And I think a lot of doctors have concerns over full body scans because you end up chasing rabbits, and you end up maybe diagnosing and treating stuff that wouldn't necessarily need to be treated and having additional tests. And so there's a lot of doctors who are concerned about it. With that said, there's a demand for it. Right? Let's be clear. I'm not opposed to it. I just want, that's the point. And I think, what I thought about is, what's the secret sauce here? Because it's an MRI machine, software package. I think the secret sauce is they've done a lot of these and therefore have a comparable database that they can then get smarter and use AI or machine learning to compare images. Maybe that's the secret sauce because, what's the barrier to entry? So what's your thoughts?
I think that's right. From a health policy and health system in our country point of view, my view is that more optionality for patients. If someone wants to get a full body MRI and do a very detailed blood test for every marker we can think of, I'm in favor of that optionality. I haven't chosen to do it. Exactly what you're saying, that you're almost certainly going to get lots of yellow flags to look into more. And one of those yellow flags might save your life, but it also could drive months or years of additional testing, additional taking, a sample from somewhere in your body, and it could be a false alarm. So I think it's unproven whether it is a net positive or a net negative, but each person can decide for themselves, what I'd say.
Yep. Yeah. And as far as good raise, longevity, preventive health, I like the space. Curious to see, what is the barrier for others doing this? I'm not sure. Yeah. Maybe it's just their sort of first to market or largest, and therefore have a database. But I'm not necessarily sure that I understood that there was proprietary software that they were using, or their radiologists were any different than standard radiologists could do. Neuroradiologists for the brain stuff, body for everything else. So, but
maybe it's a first mover advantage, and I'm not sure the investment has much of a moat around it. So I agree with you there. And then there are two startups in nutrition that both raised $50 million this week, Fay and Berry Street. And they're both very similar. They just happen to raise money at the same time and the exact same amount. Goldman Sachs put $50 million into Fay, and then a group of investors invested into Berry. They both have networks of dietitians. There's slight differences, but pretty similar kind of dueling nutrition startups.
Yeah, I mean, timing is obviously interesting. I think as RFK was appointed and confirmed, we'll talk about that. But clearly a mandate that he will have is related to food, and food is medicine, and food and nutrition, and so capitalizing on some of those tailwinds sounds pretty right. I've always had a lot of respect for our dietitians and felt like they were an underused resource. And I'm not necessarily sure I knew why. And it sounds like that, maybe some of the burden related to getting authorizations and approvals as part of your routine outpatient work is part of it. And these guys may have solved that. I think the other barrier is American behavior, right? And
Yeah.
just, the service is offered. There's a nutritionist there in the Vanderbilt clinic. Most of those clinics have a nutritionist that comes with how many people take advantage of it, what's preventing them from doing it. I think a lot of it is they don't want to change.
Yeah. Right. I like my Doritos. And I know they're not good for me. I don't need a dietitian necessarily tell me that.
Yeah.
And so moving into policy, yes, Robert Kennedy Jr. got confirmed and then sworn in yesterday. And he immediately started talking about food and getting back to what he calls good science. And so, yeah, these two startups had the right timing to start long enough ago that they can raise $50 million each now to try to capitalize on this. What are your thoughts about Robert Kennedy?
Yeah, I'm just putting my sort of provider health system hat on, and clearly there's a lot to like as far as, I want the population to be healthier. Like who argues with that? I do think that we have a lot of opportunity to improve what we eat, and that can bring down costs and make us happier and healthier. So yeah, that's positive. Won't comment on the vaccine stuff. I think that's incredibly controversial. And as far as his impact on CMS, Medicare, Medicaid services, provider landscape, I think he would be pretty benign. I don't think he understands it. If you watch part of the hearings, there was some evidence that he wasn't fully dug into understanding the system. I think the more of an impact will come from Medicare, Medicaid, from Doge and Elon.
Right. Yeah. So let's jump to that. So there was a really good story in Fierce Healthcare, kind of summarizing the healthcare lobbying for 2025. And there's a lot of lobbying going on. They break it into the different categories. And so maybe let's just spend a minute. This is a good article to sort of dig into what is the policy that is being discussed. There's a lot of them. And we were talking earlier, there's not a lot of tailwinds here. So we'll go through it. A lot of them are either neutral. If the lobbying is successful, it would result in kind of a status quo or similar to the last several years. And the fight is, are we going to lose ground in this headwind, or are we going to be able to hold on? So the first section they talk about is hospitals. I think hospitals are probably the most safe, but it's a relative benefit. No one's totally safe.
I think a lot of it depends on your position, and obviously there are different levels of health systems that have dependence on subsidies for exchanges and their exchange population, or they have supplemental programs that make up a huge amount of their total revenue, or 340B. So it sort of depends on which program gets hit and where you are as far as your dependency. But just talking about some of the big ones, obviously anything that brings the insured rolls down has an impact on hospitals. So the first piece is these subsidies, right? Congress has to do something in order for them to continue. Anytime Congress has to act in order to something to continue, I'm going to put my money that they're not going to act, because historically that's what they've done. So it's not the biggest hit. It's potentially 4 million. Now, for those 4 million, it's a lot of people. But if you think about the total number of insured, it's not humongous, but it will be a hit to hospitals because those people are now uninsured and they don't have the ability to pay their bills if they get sick. So concern, they go from getting paid something on the commercial rate to either Medicaid or nothing, uninsured compensation. So that's the first one that will impact hospitals. We'll see. It's set to expire at the end of the year.
Yeah. The next thing is the hospital sort of lobbying to limit the utilization management tactics of payers. Obviously, that's a fight between two different groups in the healthcare system, and it would be good for health systems to limit that. It might not be good for payers, how that breaks down.
Right. Yeah. I mean, there's a lot of resources spent, whether it's people in medical records, people in coding, people just pushing paper or electronics back and forth, spending time on denials, doctors' time case management time, just on going back and forth on patient care. And it's not really patient care; it's a lot of paperwork. And so, if you can bring those that paperwork down, that burden down by limiting some of these tactics of just denying things off the bat, I think that gives hospitals where they can cut those resources or deploy them to patient care.
Yeah.
So that's a big one. And listen, I think they're taking advantage of the timing. There's a lot of focus on it right now. So that could be a nice tailwind. It really could.
Yeah.
That's one of the few tailwinds that we have potentially.
And then a concerning one, again, let's fight to try to keep the status quo, is the 340B program. That's been a really valuable program for health systems that is, in the crosshairs maybe.
Yeah, I'm interested to see the Doge and Elon sort of press conference when they dig into 340B to understand it. I think their ears are gonna
their head might explode from
for those that don't know, and listen, I never had the ability, with one exception, to use 340B, because as a for-profit system you have zero ability to do it, even if you serve more underserved populations than your competitor who's not for profit. So right off the bat, that's just weird in my view. So, okay.
Looking like a true investor-owned operator.
Right. Investor-owned operator, right? So just because we pay taxes can't have access. With that said, the intent was that high-cost drugs needed to be discounted so that health systems would deliver those to patients and not cut those services because they were unprofitable. I think that was the intent, right? And vulnerable populations and health systems who serve vulnerable populations were still able to deliver chemotherapy or high cost, immunotherapy to these patients. And
that intent, I think everyone would support. I'm supportive of. Yeah,
that makes sense. How it's morphed over the years and how it gets used, I think. I don't want it to go away. I want that intent to be preserved, but how it gets delivered, I think, could be reformed.
Right.
I may get a lot of arrows for that one.
I mean, I think the drug companies Johnson & Johnson and Lilly, we've covered it on the show. They have been pretty smart in their lobbying and legal efforts to try to bring to light that intent maybe is not being fully fulfilled with the way that it's being implemented.
And it's not getting back to the patients, but that is understandable, right? Because it was not necessarily intended to make it cheaper. It's to preserve those services in communities where they might get cut. Yeah. Right. Hey, if you don't have, there are places where if you don't have 340B, delivering that service, you're having to do it at a loss because of the cost of the drug. Right. So these drug companies they're still doing fine on these drugs. Right. And to think about that is the drug itself costs more than the total payment, not including the nurses, not including the doctors, not including the facility. Just the drug alone, you're getting paid less than that. That doesn't work. And so health systems would say, well, we can't do that anymore. And then the service gets cut for the community. That was the intent.
Yeah, that's right. And so we'll see where that fight lands. There's a lot of communities where there's access in excess of what is required to keep sort of the medical necessity right. But we'll see how that evolves.
Yeah, I think the other piece, and I think don't want to skip over it, is, listen, there is, and what we covered here, Doge, Medicare, Medicaid reimbursement is the big risk, right? That's the one that is an unknown. Right. And you've got kind of a couple buckets. We'll talk about physician payments. That's a tailwind. Great. Fantastic. Hope it gets finalized. Yeah. Medicare, I think the big risk is Medicare Advantage, as well as site neutral payments. And for those that don't know, you have health systems where they may have an ASC, or there's an ASC in the market, but they deliver a similar service in an outpatient setting, an outpatient surgery. But the reason they may be a little more intense, not comfortable doing it in ASC, maybe the patient has comorbidities that they just want them in a hospital setting in case something goes wrong. Well, site neutrality would say, we don't care where you do the service, we're going to pay you the same. And obviously that could have an impact because, hospitals are staffed 24/7, 365. They've got all sorts of resources, in-house this, in-house that. And, there's a good reason to have both levels of care and doctors might want to operate. So that's a risk for some of our health systems. And then the supplemental payments, I know you've talked about them on the shows. They're very complex, whether it's UPL or Dish or just there's a lot of different programs across the country. Bottom line is, I think there's a high likelihood that those will change and probably change for the worse. Now, hopefully it's minimal because today, Medicaid does not cover the costs. And so health systems rely on these supplemental payments to be able to, make up for that and still take care of these vulnerable populations. If those go away, it's going to be incredibly problematic. Or it's not that they're going to go away. They're going to change. Could it be block grants? However it changes, that could have a real negative impact. For someone like HCA, it's not a huge deal, right? I think they said it was $400 million in total supplemental payments. It's a very little amount. For others who have, facilities in states, it could be 50% of their or 40% of their revenue.
Right. Right. And the all of these programs in healthcare have been established over the last 60 years. And which one we pull out, whether it's supplemental payments, 340B, et cetera. And they've grown and evolved through processes that you and I have been following the whole time. But when someone like Elon Musk looks at, let's take supplemental payments, so we're doing this tax and the matching, it's a super complicated process that as they look into it, I think
they're not going to understand it. I mean, you and I, listen, I still can't keep
coming down somehow.
I've been doing this for almost 30 years, and I can say going through the supplemental payments, with my CFO, it's one of the most confusing things, the timing of them, how they get paid, just depending on every state being different. We had Texas 1115 waiver and then New Mexico. It's just very different. And you remember when we had our discussion with an expert in the field, you learn something new every time. Right. So it'll be interesting to see as they dig into these programs, what they walk away with and what they're willing to mess with or not. Last year I would have thought there was our discussion that we had with that expert, he was pretty confident that regardless of which way the election went, these were going to be pretty safe.
Yeah, I think they'll be safe, but safe does not mean protected from any cuts in my mind. So I think I don't think our system in all the rural and even some non-rural areas that don't have a lot of wealth, poorer areas, I don't know how we deliver care without some kind of supplemental payment system. But that doesn't mean it's going to be set up the same way. So you'll have people that are not positioned, systems that aren't positioned that well. As far as payers, just to get back to this article, Medicare Advantage, PBM reform, and transparency, all those things are going to be really difficult for payers to navigate. I think payers and biotech and pharma probably have more headwinds than physicians and health systems. The physician and practices are probably the least impacted. I don't think they'll be non-impacted at all, but you might even get a reversal of the fee schedule. What's your perspective about docs?
Yeah, I mean, cut how many years in a row now? So, the 6.6% proposed it's fantastic. It doesn't necessarily get them back because they've been cut, but yeah, so that'd be nice to see. I think that helps. Anything that can be done to reduce them. And so back to what we talked about on the health system side, reducing burden, that's even more of an impact in a physician office. Think about a small physician office with 5 or 6 employees. You almost have a full-time person who's dealing with insurance companies and paperwork. Yeah. If you could lessen that would be a nice tailwind for them as well. So I agree. Those are the big things, making sure that fee schedule gets approved and then anything that can be done to reduce their burden with insurance companies.
Yeah.
By the way, it's part of the biggest reason they burn out is having to deal with all the back and forth related to payers. If you ask them like the least favorite part of their job, many of them would say it's dealing with that stuff.
Yeah, right. And then the digital health is a lot of focus on really just making sure that, if we extend, I think they'll end up extending telehealth, but if they do, it may not be in the exact same format. They're talking about, should controlled substances be allowed to be prescribed remotely? there's lots of discussion about that. I want to move on because there's tons to cover, but the summary is there are a lot of proposed changes and a lot of lobbying. And I think you are right that it's mostly headwinds. Maybe it's slightly less bad for health systems than docs. The Wall Street Journal had a long article about Doge's first rounds of cuts, and not that much has been focused on healthcare. They're trying to find policies that are going to be favorable to their base, cutting various things that Republican voters like. But sort of hidden in down here is the NIH grant review. And so I wanted just to call it out. There's a proposal of capping the overhead percentages for all NIH grants at 15%. And that is far less than it is today. So I've been sort of behind the scenes talking to some academic medical centers, one large one that you and I both know people at. Their average over the past 5 years is somewhere around 70% overhead. So the way that works is, just say you have a $100 million grant for the direct expenses, which is the investigator fees, maybe some lab equipment, consumables that you're going to need. Say that's $100 million. They do it over 5 to 7 years, so it would be $20 million a year for 5 years. It gets sort of reviewed and evaluated by the scientific community that's evaluating these things, and then sort of approved or not approved. And then after that, there's a negotiation with the institution about what the overhead should be. And at several institutions, it's well over 15%. This one that I'm referring to that will remain nameless is far higher. And so then the 100 million, if it was, say it was 50%, the institution actually gets 150 million over 5 years. And that excess, that overhead is designed to pay for the building maintenance and the elevators and electricity and all the infrastructure that is required. But I just think it's just how this government is looking at things, that if the base of NIH grants has grown, maybe it's grown 2x over the last 20 years, the percentage in dollar terms, of course, has grown because the law of big numbers. There's a lot of operating leverage in these systems. And so I think there's a lot of concern that that's going to be cut. Maybe doesn't sit at 15%, but it's going to be lower than the status quo.
A huge change, right? If you're going from 50, 60 to 15, and how do you do that? It just seems like that there's more work to be done. I hope that it doesn't happen in a draconian way.
Yeah.
Whatever happens, and if it needs to be reformed, it's not my area of expertise, but I hope it could happen in a responsible manner because, these institutions, rely on this, and there's vital research being done, but also it's covering overhead for other things in the system that they may not get paid for. So,
right.
Not my area of expertise, but boy, that sounds pretty draconian as it stands today.
Yeah. I mean, I think all of this stuff, my opinion is Trump is coming out with his sort of opening salvo as a way to push the discussion. And then hopefully they'll come back to some kind of tearing down to 15% over a couple of years or over 10 years or something, where the system can evolve to be responsive. But again, it's a headwind, certainly. Okay, now let's move into health systems. Tenet had earnings this week. You know Tenet pretty well. They have built up through acquisition and organic development a very strong ambulatory business that was in the earnings, really a big success driver for them. And then they also sold off a decent number of hospitals. What are your thoughts about Tenet?
Yeah, I mean, they've done a very nice job in transforming the organization. If you think back to Tenet 7-10 years ago, and contrasting them with HCA, right? Didn't have markets like Denver, Dallas, Salt Lake City, Nashville. They had some decent markets, but they had a lot of markets where they didn't have enough presence to have relevance in the marketplace, negotiating power, you name it. So they were, maybe number 3 or 4 in the market, or they just had a couple assets here and there. And that was really tough. I think their operations were struggling. They were going through financial leadership. They had some compliance issues that they had to deal with, paid a large fine. And I think that, they acquired USPI.
Yeah, that was a huge.
That was it.
Yeah.
And they started transforming and saying, listen, let's put our eggs in the USPI basket. Let's really shift towards this. We're going to keep our hospital portfolio, but pare them down to the ones where we can make, provide good quality, have relevance in the marketplace and make some margin. They probably still have more work to do there. But they've got a different portfolio and set of assets today, and one that's, less dependent on hospital earnings and more on the outpatient side. So, it's good. They made good progress. I haven't kept up with them earlier, but
the facilities they sold. So did they?
they got
places that weren't really in their density footprint.
They got out of New Orleans. That was obviously a challenging market, and post Katrina, they got out of facilities in Dallas where they just had onesies and twosies. So it was kind of a combination of maybe challenged assets. Maybe a dot on the map in a marketplace like Dallas, where, three systems, HCA, THR, and Baylor dominated. They were the fourth, right? So stuff like that just didn't, you can't do well if you're the fourth dog in the race, right? So they pared it down, really focused on operations, focused on, being good operators. Saum is into the details. He's a former McKinsey guy. He was COO. And they're moving in the right direction, and I think they've got some positive momentum. So
good. I mean, all the healthcare stocks are suffering over the last 6 months, but I think Tenet and HCA and others they're operators. They're going to do well. Now, whether the market rewards that this quarter or not is not something that I care about particularly. But in general, I think health systems, at the end of the day, we're going to have to take care of patients. Someone has to lay hands on a patient, do a procedure, let them recover. We need health systems, and Tenet's a well-run system. So
yeah, and listen, we didn't have a lot of policy issues or headwinds for ASCs, right? It didn't come up in our prior discussion, right? There, site neutrality, positive for them. That's a tailwind for them. Supplemental payments doesn't really affect them, right? They're not getting them anyway. So there's just not a lot in their way, and so it's a good. If I were a publicly traded investor looking at them, like, the more you can de-risk your investment, the better. And outpatient services, particularly ASCs, are a little less risky than hospital services right now.
Yeah. Now, on the other side of the extreme, Fierce Healthcare had a report that nearly half, it was 46% down in the article, of rural hospitals are in the red, 432 vulnerable to closing. And this is the opposite side. Like, rural hospitals, I think by definition, are benefiting from the supplemental payments, largely, maybe not every rural community, but many of them. And they don't have that sort of negotiating power with payers or the ability to attract really high-powered executive talent or physician talent, or the scale really to sort of do some of the things that a group like Tenet has done. So this was kind of a scary article to me. What are your thoughts about the rural hospital community?
Yeah, it is scary, and it's there are the haves and the have-nots, and it's just becoming more polarizing, right? And the haves are able to make enough where they can reinvest in the systems. So the have-nots fall into two buckets: one that are just losing money and holding on for trying to avoid bankruptcy or closure, and the others maybe making a little bit of money but not enough to reinvest into their people, processes, systems, buildings, equipment. And that's scary too. So yeah, I hope that it's understood how vulnerable these facilities are before some cuts are made and people take into mind, because these are the first ones to go because they don't have support networks, particularly the rural hospitals that are not part of any network. They're sort of out there, by themselves. I don't know how they really survive.
Yeah. So Paul, you ran health systems for a long time. You're not doing that today, but if you were running a rural system that's doesn't have an affiliation with a large platform, maybe there are 4 facilities across 6 counties somewhere, what can you do? How can you sort of navigate this?
Well, when you're part of a network where you may have kind of urban or suburban community hospitals associated with them, then you're part of a network. And so there's referrals that go back and forth. You try to keep patients in those hospitals to the best of their ability, right? Utilize the services to what they can. So keep patients in the community. It's good for the community. It's good for the patients. It's good for that hospital. And so you can use the network to help keep those patients, whether that's telehealth, specialists going out there, and then patients that don't need to be there, that need a higher level of care, you're transferring in. So it's sort of a hub and spoke model. You got to take advantage of every program, supplemental program you can, and make sure that you're just, running it as efficiently as possible.
So do you think
you're standalone? I don't know what you do.
More an expansion in Common Spirit or Ascension or the advocate groups like that might be interested in those affiliations? I don't know that Tenet's going to want to affiliate with a bunch of rural hospitals. Maybe they will. I don't know.
As I said, the only time we did some acquisitions, we acquired some hospitals that were rural, small communities, but it really was in the essence of, does this build out our network?
Yeah.
And if the answer was yes, and we could say, listen, if we can keep this hospital and get it to slight profitability, but it adds power to the network and it brings referrals into our community hospitals, it's worth it to do it. I don't know Ascension's markets well enough to say, are there facilities that they may want to do? But if they're out there by themselves, it's going to be hard to say somebody's going to take on that loss just for a patient to a month.
Yeah, I think that you have to figure out some way to get scale and negotiating power against the payers in order to make it viable over the next 10 years, maybe.
So LifePoint's got national scale, and they've got some rural hospitals, and so does some of their spinoffs. But so that helps, right? Because they're able to support those facilities in a better way. That's great, but they don't have a lot of regional scale, and they don't really use their joint ventures for negotiating. So their hospitals are better off because they're good operators. They're supporting them at the corporate level. They have national scale, but they don't have regional scale.
Right. Yeah.
And I think you got to have both.
Yeah, that's right. This was a really kind of scary but interesting article in Beckers. One of our subscribers sent it in to me, so I appreciate that. Shout out if anyone wants to send in stories. It's hard to keep up with all the stories, so definitely send them over. But hospital bad debt is getting pretty significantly worse, and especially in nonprofits. So the article talks about, so this is patients, paying for services or not paying for services. It's hard to reconcile because we've had, maybe not everyone covered under insurance, but a lot of people. I mean, Medicaid is, has the highest rolls ever.
Exchanges too.
The exchanges too. And so, what is your thought about this?
I don't know. It is a little surprising, and so I would jump to complications in the revenue cycle, challenges, utilization, denials are part of it. If it's patient portion, it's the middle class, lower class not having that discretionary income to pay their co-pays and deductibles, and that's a lot of what it is, Vic. Right? We probably talked about before. They get a plan, whether it's an exchange plan or through, and it's got a $5,000 deductible.
Right.
Okay, well that's they looks good, and then all of a sudden I have an emergency room visit, and I don't have $5,000.
So they're on commercial insurance or they're in an exchange plan. They're insured.
They're insured.
It's not. It's not the same insurance that our parents had or our grandparents had. It has a high deductible, and healthcare is expensive. So when you have to pay that deductible on the co-insurance, the thing that really kills people because they don't understand it. So they think they have a $500 deductible, and they do, but then they have whatever 20% co-insurance,
15%, 20%. So before you know it, they got a $10,000 bill. And how many middle class Americans or below have $10,000 of discretionary income? We've talked about before, and you've talked about you basically can't go after it. It's not necessarily good practice anyway, but you're not going to be able to do it anymore, which is go after their credit. So you don't have a choice, right? Are you going to pay that bill, or are you just going to roll the dice that the health system's going to come after you? So it's got to be that patient portion that's driving it. And maybe, insured is sort of a false net. They're insured, they're just underinsured.
Yeah. On the payer side, Humana they had their earnings. They're coming out with like much more focus on operational efficiency. They're the scaled, almost completely government payer, and hopefully they have enough scale to drive these operational improvements and navigate it. What's your thought about Humana?
Yeah, relatively new leader in Jim. He came from DaVita and then was with Envision sort of after some of their challenges, and then to Humana. So I don't know how long he's been there, but it feels like a couple years, right? So
maybe even 18 months. Yeah.
18 months. Okay. So, let's see. They're going to have to do it because we know, they're MA. Right. That's what they're doing is Medicare Advantage, and they're going to have some headwinds. So they're going to have to operate well over the next couple of years to hold ground or improve.
Okay. So then Cigna is linking executive pay to customer satisfaction. You found this story.
Yeah, I'm shaking my head.
It's a shocking story, really, to me, that, in 2025, they just now are deciding to do that.
Yeah, right. That was kind of my reaction too. It's like, there's never been a time, it's been probably 20 years that my compensation at the variable level was tied to patient engagement, employee engagement, physician engagement. And it's not, this is like your customers, right? If you're a hotel, if you're a hospital, like, what do you care about? You care about what your customers think about you. This says a lot about the state of where we are in the industry. And, okay.
It's a well-run operation.
A well-run operation.
To me, it says that until today, it wasn't important for a payer to have customer satisfaction. Or at least it wasn't important enough to make it part of executive comp.
And in what industry is that the truth? It's certainly not the case in providers, right? And I think the reason, getting to the root cause, is that we don't have a ton of choice, right? You're either you're on Medicare, you're on Medicaid, or you're getting it through your employer, or you're going to the exchange and you have limited choice, or it's not a choice because you're choosing the lower cost plan.
Right.
So we as customers, the customer, we don't have a lot of choice. And I think that the providers of that service have had us in a sort of a stranglehold position. So it's interesting. I'm glad they're doing it. Let's give them credit to say it should be done. It's fix it, but it is a little bit of a sad state to say that in 2025, it's the first time it's happening for one of our major insurance companies.
Jumping into the pharmaceuticals, the new treatments, Novartis bought Anthos to sort of add to their cancer portfolio. Novartis is, I think, operating pretty well. They don't have a GLP-1, so they didn't get that sort of a huge positive uplift. But they're sort of sticking to their knitting and I think doing a good job.
Interesting that they sort of spun it out and then bought it back.
Right. Yeah. I don't know if you saw. We'll put it in the show notes.
I missed it but you sent it to me and I watched it last night.
Yeah. So Novartis had this ad in the Super Bowl. It's titled "Your Attention, Please," and it's just a really interesting. You have to do something to get people's attention with all the noise going on, and they used the oldest trick in the book, cleavage and breasts, to get people's attention. They certainly get my attention. To then say let's focus on breasts in breast cancer and screening and treatments, which of course drives they have a big practice in that. What do you think of this ad? Is this what they should be doing or not?
I don't know. I'm not a marketing expert, but it got my attention too. I thought it was lighthearted.
Yeah.
And listen, anything that gets more people in, if they believe that this is going to drive screenings, then great. And if it shows that it works and it draws attention to the issue, it's near and dear to my heart, obviously, and anything that can drive up people getting screened, I think it saves lives. And so hopefully they'll measure it and they'll see whether it was worth the money they spent on the Super Bowl ad. I don't know. That's a lot.
Okay. And then the New York Times had an interesting story about 4 the sick and dying is in the title, but I think what they really mean is for critically ill patients in health systems and hospitals, there's been studies that music is sort of a way to ease their pain and help them heal. And they have a profile on a violinist. Have you seen this work in health systems? Do you have any experience with music?
Yes, and a great article. This is one that I should read. It's lighthearted, but it also contrasts, it's not easy to just go in there and start playing music, right? Not every patient is going to benefit.
Right.
You need to consider there's some things behind it. So, it was fun. I thought a lot about sort of the science and art of medicine, and there's a lot of science, but there's some art in there too. And I think the really good practitioners, providers, health systems understand that the healing process is more than just the actual science and technology and the care that's delivered. It's the physical environment, it's the smells, it's the sounds, it's the noises, and pet therapy and music therapy and art therapy, done correctly, can absolutely have positive effects.
Yeah, right.
It's nice to see people trying things and experimenting with it. So anything that gets the patients in a better state so that they're more relaxed, they're receiving information in a better way.
Even just the relaxation, and can they rest? Can they have their mind taken off their fears for a moment? That's all totally positive. And it's pretty cheap, right? You hire a musician to come in. I know they do it in Nashville because there's so many. It doesn't cost any money or very little money, and it's great.
Yeah, most of the time these things are done through volunteers.
Right.
Art stuff, music stuff, pet therapy, it's all volunteer related. And I think the point in this article is that not only did the patients get something out of it, but the people who were doing it get a lot out of it too.
Right. Okay, and then let's jump to AI to sort of wrap us up. So Elon Musk and Sam Altman have been feuding for, probably 10 years. But Musk offered this week to buy the nonprofit side of OpenAI for $97 billion. I think this is an effort to, sort of heads I win, tails you lose kind of proposition that Elon's putting out there. Like, he'd love to buy it and put it onto his AI platform, I'm sure. But it's also going to really make it problematic for Sam Altman to do his conversion to for-profit. So it's almost like a strategy chess game kind of thing, I think.
Yeah, that becomes sort of the bar for fair market value.
Right. Exactly.
Hey, somebody's willing to pay this for it. So yeah, it's interesting whether it's ego or he really doesn't want it to be a for-profit. I don't know, or maybe both.
I don't think it matters really. It's sort of a 6-1 half, doesn't it? JD Vance, our vice president, was in Europe at an AI conference, and the Europeans were talking about keeping AI safe and putting regulation in, and JD Vance was not constructive in that. He basically said he doesn't want to see a lot of regulation, and the U.S. will not be supportive of that. What is your thought about the sort of European and U.S. relations around AI?
Yeah, I mean, it's tough, right? And the next story we'll get into is a little scary related to AI. So
it's hard. I mean, for good or bad, I think it's probably both. The U.S. position, starting with Silicon Valley and OpenAI, and then our administration now, is just let's accelerate full speed ahead into all of this technology and kind of paper over the risks. We will figure it out as we go.
Yeah, we got to be first. We got to be the best.
We got to be first. We got to win. We got to get there. And that's going to have unintended consequences that will bring risk and some dangers, as we'll talk about in a minute. The alternative is trying to regulate it. And I don't know if regulators can possibly create regulation that will work, given how fast it's changing. But certainly there's a different approach in Europe.
Yep.
Okay, and then we talked about DeepSeek on this show a couple times. DeepSeek's the new Chinese AI tool that is very good and free. It's open source. So it's the same quality as like OpenAI or Google's product or X's product, but from the Chinese country. And it's open source. So lots of people now are offering it. I have it on 2 different sites I use. But this story is talking about it doesn't have the same kind of guardrails that American companies have chosen to put in around bioweapons or self-harm. And that's an example of where it could be pretty scary to not have regulation. And I think that's the world we're moving into.
So, I mean, this is a classic. The good and the bad is so it's open sourced, right? I mean,
Right.
it's easier to jailbreak is the term they use.
Right.
That what it's basically saying is, listen, it's great and less expensive because of that, but it's also riskier.
Yeah. And there's no advice in the article. It's just like, this is an issue, and then it ends. And that is pretty scary, where, people can learn how to do things in biotech, for good. They could try to invent some new cure for something, but you could also invent the opposite of a cure, something that would be not so good.
It will happen, right? It's going to happen sooner than later, where something, I mean, and it'll be sad when it happens, but it won't be surprising that it's a bad outcome because of this.
So we'll keep monitoring it. I think we are already with, the genie's out of the bottle. I don't think it's going to be possible to put it back, but we need to keep monitoring all these things. And then there's a lot of concern over the legal rights of AI companies to basically take the entire internet, a lot of which has IP copyright protection, and the AI tools sort of ingest all of that and then can answer, very detailed questions, even word for word, about maybe what an author wrote in a book, or what some newspaper wrote about a story. And there's a debate around, since it is being transformed into these, let's call them algorithm or parameters, and then used for all different purposes, is that like a fair use doctrine, where we're learning and then we are able to use this information in a new way? Maybe. But Thomson Reuters did the first lawsuit, I think it was 5 years ago. So it was before any of the generative AI movement. But they won the court battle, and the AI company that took a bunch of their it was a legal subsidiary, it had a bunch of legal case analysis. They won that this AI company cannot use that in their product. And so that is just something to watch. I think it is. Listen, I'm a venture capitalist, so I'm in favor of IP protection. A lot of my companies have intellectual property. But I also think that the genie's out of the bottle, right? So all these companies have already scraped the entire internet, and there's billions of dollars that have been put into this. I don't see how it's going to stop.
How did the AI company get access to proprietary data? Was it like just out there? And that's what I didn't understand.
Yeah, so the case laws are out there, but then Thomson Reuters has sort of it's almost like an editorial thing, or their view of what you should take away from this that's on top of that, or I think it's on the header. And I think I just read this story, I don't know all the details, but I think they got that by paying for the subscription and then just taking it.
Gotcha.
And then they hired another firm as like a workaround to do a similar thing, but maybe not as high quality or not as extensive, that they also put into their machines and acted like that was all fine. And Thomson Reuters won. So they're going to not be able to do that.
Yeah, that's
quite different than the generative AI that sort of just takes everything in the world in, and then you have this machine that can quote you, the entire chapter from a Harry Potter book or whatever. It has all that knowledge somewhere in there. I think that's going to be a different type of case study.
Well, it also brings up, how much is that proprietary data going to be worth in the future, whether you're a health system or a fertility company or Thomson Reuters, to say, listen, we'll open this up to you, AI company, but here's the cost. Is it worth it to have access to this proprietary data?
Yeah.
You can't get on the web, hopefully.
Right. Yeah. I mean, I think there needs to be some kind of negotiated settlement, but just interesting that the first big case was won by the IP holders. So
Yeah.
we'll see.
Yeah, that makes, now that you explained it, it makes a little more sense than my sort of skimming it, right? Yeah, they sort of behind the scenes pulled their data and used it in a model. That seems pretty.
Yeah, right. It was before the generative AI transformer model thing existed. So, okay, Paul, I know you got to run. Really appreciate you stepping in and filling Marcus's shoes. Really helpful with all of this policy around health systems and healthcare policy. Great to have your perspective.
Yeah, man, it was good catching up with you. Miss hanging out with you and Marcus. And I'm gonna come visit you guys when I get back into town.
Once ski season's over, you'll be back in town.
That's right. Hopefully he's raising a lot of money, doing whatever he's doing over there. And I'll look forward to catching up with you. But keep doing good work. I enjoy the show. I enjoy listening to it. And anytime you need me, I'm here.
Okay. Thanks, Paul. Appreciate it.